Well, good morning, good afternoon, or good evening from wherever you're calling in, and welcome to our MPWB webinar. This one is entitled International Medical Physics Guidelines for COVID-19. My name is Parminder Basran. I'm the Director of Communications for Medical Physics for World Benefit. Medical Physics for World Benefit is a nonprofit organization whose vision is a world with access to effective and safe applications of physics and technology in medicine. MPWB's mission is to support activities which will yield the effective and safe use of physics and technologies in medicine through advising, training, demonstrating, and participating in medical physics-related activities, especially in low to middle-income countries. One of our objectives is to work in the spirit of collaboration by working with our colleagues, partner agencies, and national and international organizations to collectively improve patient care. Our first COVID-related webinar, sponsored by Medical Physics for World Benefit, was entitled COVID-19 Related Issues, a Medical Physics Perspective from Italy, and was presented by Dr. Antonella Del Vecchio from the Department of Physics in Milan, Italy. The webinar was extremely well received with nearly 700 attendees. The video of that recording is available on our website at mpwb.org. And one of the things that we learned was that from our survey was that about 95% of respondents indicated that they would be interested in a follow-up webinar. So to this end, MPWB is hosting the second webinar, and we're fortunate enough to be able to provide an opportunity to learn from each other by offering this webinar featuring medical physicists on the Eastern Hemisphere, with the hope that this webinar is more accessible to colleagues in that part of the world. Our agenda for today is as follows. We're going to have about 50 minutes for this webinar, and the first thing we'll do is introduce our speakers. First, we're going to hear from Dr. Jin, and this will be followed immediately by Dr. Kron. And then after Dr. Kron's presentation, we'll have a question and answer session where questions that were submitted in advance and those posted during the session will be asked to each speaker. The last session, we had over 70 questions asked during the session alone, and we were simply unable to scratch the surface of the number of questions posed. So to help focus and distill the questions from our attendees, we have arranged for one of our board members, Yakov Pittman, to review the questions and distill them for us. Throughout the presentation, feel free to type in your questions using the area on the right of your screen. And the last 5 minutes will be devoted to final words from the speaker, closing remarks, and a note of thanks. And again, this webinar will be recorded as our previous one, and the link for that will be posted on our website. So it's my privilege to introduce the speakers for the webinar. Our second speaker is Dr. Tomas Kron, who's the Director of Physical Sciences at the Peter MacCallum Cancer Institute in Melbourne, Australia. Dr. Kron is a radiation oncology expert and will be providing a brief overview of their conditions in Australia and summarize details of a report and he and several co-authors have published with regards to guidelines in coordination with the Australasian College of Physical Scientists and Engineers. And we'll provide a link for that publication at the end of this session. Our first speaker is Dr. Xiance Jin, the Chief Medical Physicist and Vice Director at Wenzhou Medical University First Hospital in China. Dr. Jin is the chair of the Education and Training Committee of the Asia-Oceania Federation of Medical Physics and is the lead author of the AFOMP guidelines for radiation oncology operation during COVID-19. A link for this document will also be provided at the end of this session. So we're delighted to have he and Dr. Kron here for our webinar and share their knowledge on these important topics. So without further ado, I'll pass control over to Dr. Jin for his presentation. So let me do this.
Okay. Can you hear me?
Yes, we can hear you.
Okay. Thanks, Dr. Basran, for the introduction. And really thanks for giving me this opportunity to show some of our experience about the radiation oncology operation during this COVID-19. This is Xiance Jin from Wenzhou Medical University, first affiliated hospital of Wenzhou, China. So I'm really happy to hear, so now I go straight. Currently, I'm served as the chair of the education and the training committee of the AFON, and this guideline actually was edited and approved the AFON XCOMS. So I will just present on behalf of this AFON XCOMS. First, I would like to show you where I come from, Wenzhou, China. This is a map of China. So actually, Wenzhou is in a province called Zhejiang province. It's here located in the southeast of China. It's next to Shanghai. Probably you heard about Shanghai. Oh, the capital of this Zhejiang province is Hangzhou. I think it was 2018, the G20 city. And Wenzhou is located in the southeast part of the Zhejiang province. So this is the location of my city here. And on this screen, also show you some of the latest numbers of the cases confirmed. Like in China, the totally confirmed case was more than 84,000. And about this is 4,600, more than 4,600 for China. For Zhejiang province, it's also very serious affected during this pandemic. There are more than 1,200 people were confirmed, and one death happened. Unfortunately, this was happened in my city, Wenzhou. So Wenzhou, there are about 504 confirmed cases and one death, and the other 503 was cured. So that's the basic idea. The city, we actually locked down the city during this pandemic. We locked down start from January 29th. So about 3 weeks, we reopened the city. During this lockdown, the community was shut down, the park, the shopping mall, everywhere shut down. Citizens are not allowed to go out. You need a special some documents when you try to go to shopping or go visiting the hospitals. I will talk about later. Fortunately, there was no new case report since February 18th, so that's why the government thinking reopen in 19th February. So this is the background. So when the city reopen, there's still some requirements, like say the citizens still need to wear masks wherever you go, like go shopping and go school. No school we haven't happened yet. So you need to take the temperature wherever you go in the entrance, supermarket or shopping mall. You still need to wear the temperatures. In China, we need to show in your telephone, in your mobile phone, you will show the triage. We call a green code. The green code means you are safe, but if you show the yellow or red code, that means you have a potential dangerous by have a close contact with people or suspect the case or someone had confirmed the case. You come from some area that they have been confirmed the case there, so you are not allowed to go out. You need to quarantine in your isolate in your home like for 14 days probably until the code is turned to green, so you can go out again. So for the radiotherapy, we resume like February 3rd. That's about couple weeks about the 4 days out of the lockdown, because we think the radiotherapy, radiation oncology is kind of special. Lots of patients was stopped halfway because our Chinese New Year. So we think we need to reopen to continue the treatment for the benefits of these cancer patients. So I say during that time the city is still locked down. So the patients or other citizens, they need to if they want to go out, they need to wear a mask. They need to. This is kind of special passport provided by the government. You have this passport, you can go out for shopping or visiting the hospital and taking temperature, but everywhere. Even people can stop you halfway on the street to take the temperatures. But finally, we think of the cancer patients. The cancer patients appear to be started to be reported to be at an increased risk for the COVID-19 infections, and the outcomes are worse for patients for cancer patients compared with those without cancers. And these cancer patients are vulnerable to infection due to their compromised immune system due to cancer or due to the active cancer treatment. So most because many of the cancer patients are elderly and more susceptible for these infections. So as we all know, the radiation oncology department are more complex compared with other departments. Like we have different kind of people. So like say we have cancer patients in our department and their family members. We have doctors, nurses, therapists, physicists. Also we have engineers or other support personnel. So first thing, we would like to divide our department into different areas according to the potential risk levels. Like the waiting area, it could be potential contained because patients who are waiting here. But the treatment room and the entrance, the triage is kind of dangerous. So when if their case happen, most often they will happen in the entrance. So we divide first. We divide it to different rooms because we try to stop the crossover by the patients and by the also the medical staff. So we don't everyone go to their areas directly. They don't cross over frequently. As for the general management, so I think the first thing is we need to establish a coordinated unit. So we know who is the leader in this management system and establish excellent links and report lines. We need to, the staff members need to know directly who to report when there's some case happened that could have happened. So in some case, one patient dropped in and have a high temperature, and the staff, medical staff need to know who to report and how to report these cases, how to handle these patients. So we need to develop general rules for prevention and personal behavior so we don't cross over. We'd probably like to split the staff into different groups or teams. So that's also, we don't want all the people work together. So in case there's something happened, we have backup group, we backup staffers to, otherwise the whole department could be shut down. So we also want to go over the department procedures. So what kind of patient can be postponed, and maybe some patients need to change the fraction schedules, like say with hypersphere fractions. So yeah, the last is important is establish triage process at the entrance. So we need to, I will talk later. I ask the patients, do they have the potential contact with the people from Wuhan that time? Could be potential risks of being infected. Yeah, that's the triage. We have two levels, like the hospital levels. We have automatic temperature measure. When people go through, on the screen it will show up the temperature. If it's high, if it's about, I think it's 37.5 degrees, it will stop him to take additional measurements to make sure the patient was safe. And in the department triage, the nurse will ask more questions. They ask the patients or their family members. They need to fill out a form, like clearly ask them, have they been to Wuhan for the last 14 days? At that time, Wuhan, yeah. If you come back from Wuhan or you have a close contact with someone from Wuhan, possibly do you have the high temperature or other symptoms, the cough? So when everything goes clear, the patients and their family members were allowed to go into the department for the treatment. So the patients, the patients, you need to wear a mask. That's the basic requirement. So social distance, we usually have, we will treat about 200 patients per day. So usually the waiting room, the waiting area was crowded with patients and their family members. At this special time, we were allowed only like say half hour, only 10 patients or 10 members, their family members in the waiting room. So we can keep a distance like 1 or 2 meters between each one. So we have a clearly demarcated waiting area for someone. Patient could be have high temperatures, get a fevers. So patients also need to be informed, educated. If they have some symptoms, we will clearly tell them who to report, their how to reach their physicians, like say report to physicians, and how to get additional measurement to make sure they are safe. So this was informed, educated for the patients. Staff also need to be informed, educated, because in our department, like say, we are not all the physicians. We have someone like therapists, like medical physicists or other engineers. We actually do not have much background on the medicines. So the staff also need to be very well informed, educated, like say where to look when something happens, when a case comes, who to report and how to report the cases, how to handle the patients, and also ask them to have good protection for themselves and for the patients. Like we will usually we are rotate the work schedules. Like I said, we need to separate the staff into different groups. Like say we don't work all the groups in one day. We are rotated. So in case one group has some suspect case, we still have backups. Yeah, staff members are ask them to limit their mobility and the crossover during that time. You stick yeah in your area, in your work. If you have something need to communication using the social media like telephone or phone or social media, we have web chat and in this time. So as for the protective equipment and levels, as therapists, they have a direct contact with patients, so they have a kind of high level of protection. Secondary or tertiary, we say we need a double gloves. Or oncologists, the same. If they have consult the patients, they have direct contact with the patients, they also need a high level of protection. And the triage and the medical physicists, this yeah, actually triage, they only ask to fill out the forms, so taking the temperatures. And the medical physicists, we can reduce the possibility to contact with patients. We will limit their contact as possible as we can. So actually the protection level depends on their working environment or the available or their protective materials. Like this is showed the therapists in Wuhan, how they protect themselves. They're like physicians in the infection department. Like in our department, we are not very serious, kind of as that serious as Wuhan. So the therapists here are just working clothes and the gloves and the mask, surgical mask, and the hair cap. So it really depends on, yeah, if you have more protect materials that you can risk your protective level, that's good. Disinfection, all the equipment, like treatment equipment, simulation equipment, operating consoles, or all the equipment after the treatment, after they need to be disinfected. And at least twice a day at noon, we have in the day off. So at the end of the day or anytime when there's contamination happens, we need to disinfect it. So when you see some pollutants, you need to disinfect it. Ground disinfecting things, so all the rooms like office, doctor's office room, physics room, accelerator room, simulation rooms. So again, if you see some pollutants, you need to remove them and disinfect twice a day and anytime when the pollution occurs. Yeah, we do have, because air disinfection, because of our department, the treatment room was in the basement. So the treatment room we would disinfect at the end of the day, and we use circulating air disinfectors like these machines running 24 hours a day. So we also use ultraviolet radiations 3 times a day when stop when there's no patients, no staffers. That's it. Medical waste, we will treat at this special time all the patients with waste we regarded as infection medical waste. So we will strictly follow the management of medical wastes. All the protective equipment for examine directly were discarded after the examinations. So yeah, when you're dealing with, we need a double layer sealings, clear marking, and airtight transportation. So that's kind of strictly. For the brachytherapy, this idea was brought up by Dr. Kron. Yeah, actually he brought up that idea. So we think the general considerations were applicable to brachytherapy at the same time. We were probably considering reduce the number of fractions procedures, so reduce the risk of the infections. Yeah, the same. We also need to split the teams into different groups. So maybe we need to check the availability of the source. So because generally the national transportation was shut down for, I think it was shut down for 3 weeks or 1 month nearly. So I don't know, different country maybe have different time or shut down. So we will need to check the availability of these sources. And at this time, if you couldn't get a new source, probably we need to lose the activity restrictions. Yeah, we need a close collaboration with the vendors. How they can, how you're asking if they can provide additional source. Yeah, that's basically I think that this is tough time. It's a battle between people and virus. The people working in the first line, in the front line, was very, it's exhausted. Yeah, but during this time, we still need to protect the safe to the all people, to the medical staff, to our patients and their family members. I think life still moving on, so we still to move forward with colleges. It's very important, I think, for the radiation oncology department to running at this special time, because we actually in our department, the surgery we have half of the department was shut down. They stopped the consulting, stopped the treatment for 2 or 3 weeks because of the city shutdown. People generally the patients cannot come out to the way to visit only in some emergent cases, right? So this encourages the people in the hospital with safe productions. And actually, yeah, we do increase the economic incomes for hospital during this special time, right? Yeah, the final the acknowledgement. Actually, thanks to the Dr. Aaron, Chuckler, he's the president of the AFON. So actually, he brought up the idea, say we need to, as AFON, we should come out a guideline for our communities. Yeah, that's his idea. And also thank the EXPO members. Yeah, Iwa, Bisak, Hasin, Anapama, Azera, yeah, Tomas Kron, and Hajime Mongzen, and Chai Hong Yong, and Konik, and Tesu. So they also help to edit these guidelines, and also thank my colleagues and my family members. So I think basically this is my brief introduction of this my guidelines. Okay, Dr. Patterson.
All right. Well, thank you very much. That was fascinating. And we have, I can think of many questions off the top of my head that I'd love to ask, but we will wait till the end of Dr. Kron's talk. And so now we'll move directly to Dr. Kron. So Farhana, do you have the ability to transfer control? Thanks.
Thank you. Thank you very much. I'm not sure if you can hear me.
We can hear you.
Bringing up my slides. Excellent.
Yeah.
So here we go. Let me just see if I can. So thank you very much for giving me this opportunity to present something about the considerations of a radiotherapy department and a radiotherapy physicist like myself from Australia and New Zealand. As my Background, I am the Director of Physical Sciences, which includes biomedical engineering and medical physics in a cancer-only center. And you can see our beautiful new shiny building there. Having a new building has distinct advantages in the context also of COVID, being fully wireless in terms of the IT infrastructure helps tremendously. And also the ventilation of rooms is good enough to cope with procedures which may produce aerosols. That is clearly one of the problems we will be talking about briefly. Our center has an oncology focus, and our group is mostly considering service provision, but we do have also some research operations. We operate on 5 campuses with 16 linear accelerators, so we are a rather large group, and the physicists mostly service radiation oncology. I have no relevant conflicts of interest to declare, but I would like to thank already my colleagues from AFOM, in particular Jin, and my ACPSEM colleagues from Australia, New Zealand, and the staff at Peter Mac. And of course, AAPM, Jake van Dyke, and Medical Physics with World Benefits. What I'd like to do in the next 10-12 minutes is to review where Australia and New Zealand stand in the COVID crisis, introduce our publication on considerations during that, during any pandemic really, and to highlight some of the specific measures we at Peter Mac took in preparation. It's interesting to note that on the shop floor, guidelines, considerations, and publications are not necessarily working, and some of the things we actually then do in practice are not identical to what is in guidelines. And I think that is an important message overall for everyone, that flexibility in its response and a measure of the local abilities, the local opportunities and threats is really important to work in an effective way. This slide is something many of us have looked at for many times in the last couple of days and weeks. And you can see here the curve of confirmed infections. This is a log scale here on the left. So it does go very steeply up here. You can see Australia and New Zealand both have managed to flatten the curve. And that is obviously good news. And it is at least in good part due to the fact that we adopted isolation and social distancing measures and restrictions to services relatively early. There are some sobering points, though, to make in these curves. First, if one looks at Singapore and Japan, one can still see that there is, even after flattening out over and over again, there's still second waves, third waves of infections, because if there are only thousands or 10,000s or even 100,000s of people infected, immunity throughout the community isn't really given. And second waves may occur. You can also see that if I project the Australian curve out further and further, we do reach the peak of infections very, very late. At the moment, we are thinking about August, September, which means that a lot of the things we are doing now will be there really for the long haul. And a number of rather unusual measures have been taken in Australia. For example, the beaches were closed, and last weekend the government decided that at least some beaches would be opened again, which was very exciting for Australians, as you can imagine. It was so exciting that the beaches actually crowded very quickly and were closed again after 3 hours. Interestingly, also the government is now advocating an app where every person is invited to use an app on their mobile phone, which basically just traces where a person has been and who the person has been in contact with, mostly really with the idea to identify if someone was identified with having been infected, that everyone who has been in contact with that person can be notified straight away and appropriate tracing measures can be taken. I have downloaded that app myself. But these things are not new, and physicists actually have tracking apps already much earlier introduced. Certainly in our hospital, we introduced a tracking app for physicists, which is typical physics stuff, a spreadsheet, where we basically just record all times when physicists and physical scientists, biomedical engineers were in patient contact with a whole variety of different activities. And that takes us to the paper, which is freely available to everyone. The link was, I think, on the web page of Medical Physics Without Borders. And the objectives of that were somewhat different than the AFOMP ones, trying to complement what is in AFOMP and being really rather specific about physics considerations. They are considerations, not necessarily guidance or not prescriptive, but try to provide practitioners and medical physicists with a list of considerations, a structure how one could respond to a pandemic. And we took, for example, also the responses from earthquake, which there are quite a number of them in New Zealand, of earthquakes responses into consideration when looking at that, and provides arguments for physicists to the outside world as to why we do certain things. One thing we started off with was trying to identify what are the different tasks physicists do and what are the different groups of physicists there. And the first thing, certainly in our hospital, which became quite obvious, is that physicists are seeing patients. Physicists are not removed from patients, and it is not really feasible to take us completely out of their patient-facing equation in things like motion management, in things like brachytherapy, in vivo dosimetry, total body irradiations. It's the complex stuff where physicists are actually seeing patients, and there is this patient-facing group. There are safety assessments, and you can see here for yourself the different tasks. I don't want to say some tasks are more important than the others. That's really not the idea. But the idea was to try and put together groupings which we can associate with a type of staff member required in terms of experience, in terms of ability to work from home if they have family, or if they have elderly or vulnerable relatives. We also, in that publication, looked at practical considerations for work, looked at different categories in this context, and I can't really emphasize enough how important the IT provision really is in terms of achieving remote access. It is a key enabler for that. It's also a key enabler for teleconferences, which we now enjoy at great frequency. I used to have 2 teleconferences per week. Now I have at least 15, typically 20 or even 30 teleconferences to attend, which basically replaces meetings and allows me to work 2 days a week from home. Medical physicists also often have an IT role because in radiotherapy departments are very much IT heavy and are often good people to talk to the IT department because we have at least partially a similar language and things there. All right. These are the other categories we looked at here, and I just wanted to mention that management is clearly not something which should be forgotten. That is obviously project management, commissioning of things, safety, and so on, but also coordination between staff working at home, coordination between and staff working at site, and coordination between different professional groups. Working from home did play a very important role in our considerations because it did present us with particular challenges. About 30% of our staff do work from home, One of the very interesting questions which was put to us right at the start is, what should we do from home? What can people add if they are sent home? And all the research staff, for example, were sent home, and we developed a list of things which could be done from home, starting with completion of in-services, something we are often really quite slack at. I finally want to finish off with sort of highlighting a couple of special things in the Peter Mac, my institution's response as such. And we went back really to the SARS experience in Singapore. And I can't emphasize enough how much literature there is actually out there of people who had all sorts of different encounters of volcano eruptions, earthquakes, and obviously the SARS epidemic. And what we learned from the experience was that staffing numbers really play an important role, and we followed that model with a 5-level response plan, which basically started with minimal staffing impact, and then planning what should happen to our patients in a clinical plan if the staffing numbers are reduced because of school closures, because of infections, because of a whole variety of other things. We went straight to level 2 early March, and that basically meant postponing benign radiotherapy, engaging in hypofractionation in a very big way. That includes also brachytherapy, ramping down prostate brachytherapy, but maintaining gynecological brachytherapy, moving to more single fraction SBRT treatments, and trying to consolidate our approach, trying to minimize the number of times patients need to come into the clinic, but also trying to minimize the impact a staff reduction would have on us. It's interesting why we went straight to level 2, and that sort of brings out a particular problem in radiation oncology. In radiation oncology, what I do today really affects us for the next 6 weeks. If a patient is planned today and they will have a fractionated treatment over 6 weeks, then whatever we do now in terms of response is something which will be with us for a long period of time. And if you look around to different medical specialties, that is something which is really rather unique for radiation oncology. As such, we went straight to level 2, but now since the curve is flattened last week, we went back to level 1. Sobering observation in this context is also that the reduced activity, in particular if it's sustained for a long period of time, does mean that insurance companies will pay less money to us, and there is an income reduction, giving us less financial flexibility. It's exactly the same as individuals who are out of jobs. We are earning less, which does mean that we do need to look forward also to future LINAC replacements, future things, and see how can we best manage all that. Within physical sciences, biomedical engineering staff was really the key people, because they work in operating theaters. And if you think of what is required, ventilators, well, it's the biomedical engineering department. They went down into the cellar, into the storeroom, and basically got everything which looked like a ventilator and got it back to work. In our larger campuses, which are 2 of them, we segregated staff into patient-facing and non-patient-facing group, trying to align with the therapists' grouping, and sent most research and 30% of clinical staff home. We are very fortunate that we have VPN access to the hospital network, and the department purchased headphones and microphones like the ones I'm wearing here for everyone. We are really fortunate that 2 years ago we put our treatment planning system into the cloud, which means it is it's easy accessible. We also introduced every day at 10 o'clock a 10-15 minute teleconference where all staff are talking to each other and planning the day. The interesting part of that is that it works very well, and it does work also 2 ways. It does allow us to check on people who work from home to make sure, are they at work? or at home, and are they okay? Are they all right? We're also starting now to actually look at what changes have we adopted in practice, and actually which changes are there for the better, like hypofractionation, shorter and better prepared meetings, and some of the work from home. And certainly this morning huddle coming together and discussing the day's work is something which we would like to maintain. So we don't want to throw out the kid with the bath water, so to speak, when we return back to normal, whatever that may be. The conclusion of the paper is shown here, and I think it is important that the things, the opportunities and the challenges we are facing are there to provide us also with a new way of working together. It certainly has improved the communication between the different groups, professional groups in the department, and I hope that we will see the sunshine and sunrise again on beaches all over the world. Thank you.
Thank you very much for that outstanding talk, Thomas. That was really, really full of information. So now we're going to go toward our question and answer session. So we have a couple of prepared questions in advance that we'll ask our attendees, and there are a few questions that are rolling in through our chat discussion. So let's start with a question that I'm posing here, which is, let's start with Jin. What do you feel has been your biggest operational challenge since the beginning of the pandemic?
Okay. I think the biggest challenge still is how to manage your patients, because as we know, the cancer patients, they are, even without this COVID-19 in their daily life, due to their cancer or due to the active cancer treatment, they are either get be infected. So normally during the treatment, during the radiotherapy, they will get a higher temperature, but you know, about 37.5 or something like this. But that will be fine during our daily normal life. But during this pandemic time, when the patients come to your department and say you measure it and they find a high temperature, that makes trouble. What we're going to do, we need to stop all the treatment for these patients. We need to ask the patient to do additional measurement to make sure everything's fine. But for the diagnosis of this infection, we need to, like, say, temperature and CT or other blood tests or some the testers. But at the beginning, this test takes longer. It takes about more than 24 hours to, you know, to get the results. So the patients will be also your question, why I need to take this test? So I'm come here to treatment. You stop my treatment and taking me somewhere else, and you know, very seriously take some isolated them and for the testers. So only out the results comes negative, they can come back to the treatment. So I think this causes a lot of trouble, and most of the time we are dealing with this kind of trouble during the operation during this pandemic.
Right. So the logistics of what happens when patients have positive tests or they're not sure about it, and then having to reschedule both the radiation therapy and the imaging and all the other appointments. Yeah, this is a really challenging question.
Yeah.
So what about yourself, Thomas? What do you feel has been the biggest operational challenge?
Obviously, I agree. Patients and maintaining patient focus in these days, and ensuring that society and hospitals see cancer still as a problem when everyone is and every emphasis in the hospital is on COVID, to ensure that the patients still are treated is important. I also would like to sort of go back really at the very start. And one of the bigger operational challenges was to make sure that staff would take this seriously. That sounds now, several weeks, months into the pandemic, a bit funny, but I think certainly at the start there was oh yeah, we've been there, done that attitude, and I think it was quite tricky or interesting to get people across the line to take that seriously and act upon it. And I'm really grateful to all our staff to having done that very quickly.
Yeah, there's an excellent point that often is quite missed, is the importance of leadership and just the cultural surrounding in the community, and how people are experiencing this pandemic within their communities, and the ability to put that into context of what's happening outside of their cities, borders, and whatnot. It's a fascinating perspective. Another question for you both, and I really liked both of your talks, because you both really sort of emphasized this notion of communication and how it's very important in this. And so the question maybe is a little bit thinking forward about how has this pandemic changed your multidisciplinary communication? So for example, have you found that the way that you're communicating with your different disciplines has changed for the better or for the worse? So Thomas, could you have any comments on that?
I would say clearly for the better. Better because I think the interconnectedness of the department became much more obvious. Once people understand that what social distancing is, and it is actually interesting that I think in the beginning people were noticing their co-workers more when they are 1.5 meters away from them, or 8 feet, or whatever the distance is different jurisdictions adopt. But you realize that you're working with someone more if you have to keep a certain distance. So the communications were becoming more effective, and meetings better prepared, and clearly also more regular. We found that people attend meetings more punctually overall, and are generally better prepared. So I think that has improved.
Yeah, it's excellent. It's interesting how we're social distancing, but we're actually also being put closer together in a lot of ways. How about yourself, Jin? How do you feel about how has this changed your multidisciplinary communication?
I agree with Dr. Kron. Yeah, it's kind of bad, but in China it kind of a bit different. Can you hear me?
Yes.
So we actually we have social media. It's very popular. Far behind this pandemic, we call it WeChat. Actually, in normal office hour, we have we call group in the WeChat. We build a different groups for different purpose, like say the communication between medical physicists, communication with therapists, or cross communication with nurses or physicians. We kind of already used to communicate on this virtual way. So at the beginning, it didn't affect too much about the multidisciplinary communication at all. But what happens is when the case discussion or the border meeting now it's forbidden, it's limited. So we move this meeting, go to virtual meetings. So that's, I think, the only affect the face-to-face contact for the case discussion or border discussion. So other things we already, I think in China is already, we are very used to communicate by the social media ways.
Right. Okay. It's very interesting. Let's go to the next question. So this has to do with specialization, and so when you deliver specialized therapies like stereotactic radiosurgery, you often need to have some expertise. And so the question is has the pandemic changed individual scopes of practice? So Jin, do you have any comments on whether medical physics practice has changed? Have people been forced to become more experts or become more generalists?
Yeah, it's kind of, yeah, as I said, the communication between like physician and the medical physicist here is it kind of through, we can in that WeChat, the social media, we can send the pictures or any patient's CT images or the data. The do like say we have to, you know, the physician part side, they usually the physician like to come to the medical physicist office. They like to do the control side by side with the medical physicist, so they can. Some of them are not familiar with the treatment planning systems, so they like to sit aside the medical physicist to ask them for help, frequently. But this time they have to, like say, change their way. They need to work, social distance on their own offices alone, so to draw the controls. So that's kind of part for the physician. They need to change their way of the practice.
Right. Yeah.
Yeah.
Interesting. How about yourself, Thomas? So what have you noticed any changes in the way people are practicing?
I think the starting point was really to realize that we are not generalized enough and potentially too specialized, because if you segregate teams into two different groups and each of the groups ought to be able in principle to do the same thing, it becomes very quickly obvious that that may or may not be the case. So we did try to introduce some a bit of training and selected the people being patient-facing in a way that they had really a broad skill set there. So I think what we see is probably decreased specialization, which has, on the other hand, a somewhat tricky effect on education overall, which becomes a bit, which obviously is becoming more difficult. In particular, if education includes practical education and showing residents or junior physicists or very senior physicists like myself something how things are done. To do that in a virtual way or to do that in a segregated way is clearly more tricky. So I think I certainly have learned more about the value of generalists.
Right. Yeah. Thanks. So let's go to some of the questions that have been posed online. There was one question that was related to how patients are treated, and I think Jin had provided a couple of slides on that. So maybe, Thomas, maybe you could provide some comments about how COVID-positive patients were treated, or if they were treated within your facility, and what sort of precautions are in place.
We are fortunate so far. We have not had a COVID-positive patient for treatment. That in other hospitals that is the case. Our state is sort of trying to consolidate or put plans into place for consolidation. There have been long debates and long discussions about PPE and staff wearing PPE, with the health department's advice being mostly that this is not necessarily helpful. That applies obviously not to areas like pediatric treatments where aerosol generating equipment like general anesthetic is in place, and in these areas everyone is wearing the full PPE. Always taking into consideration that surgical masks really only protect people from the person wearing the surgical mask, while proper PPE is required for staff who may need to protect themselves. And the hospital has very quickly started new training courses for staff how to actually use PPE. And I was on the verge of cutting off my beard already twice.
Yes, interesting. So Jin, there was one question that maybe you could answer, and that was directed, you mentioned in your presentation that the machines are cleaned twice per day. Is that true also for the COVID positive patients, or was there some additional cleaning required?
Yeah, as I just want to mention that if the patients were with confirmed case was positive with COVID-19, the policy here in China will be the treatment will be stopped for these patients.
Right.
Yeah,
Right.
yeah, because we think the COVID-19 was more acute than the cancer. Cancer can develop slowly, but if the patient get infected by COVID-19, when the acute symptom comes out, it's more dangerous. So other case, the other side is when the patients infected, is most likely the more people will get infected by let him in treatment or other place. So as long as the patient was confirmed with the positive COVID-19, he will be sent into some infection department right away.
Okay.
And all the contact personals, family members, medical staff will be quarantined for 14 days.
Right. We might have time for maybe 2 more quick questions. So there was one question with regards to brachytherapy and if there were any additional precautions for staff. Thomas, do you have any comments on that? Were there any? I think that you mentioned that there were no significant changes in precautions for staff, correct?
Brachytherapy is done in the operating theatre anyway, so I think that is a sterile environment. So that didn't have any changes. The main changes occurred really in the way the staffing was grouped and rostered. We created 2 separate teams in brachytherapy, which were did have different offices, different planning spaces. Everything is sort of different. Or a gynecology and a urology team, which really only communicated by phone. This is something which was clearly new and done because of the idea of segregation.
Right. And Jin, do you have comments on that?
No, I don't have comments from this. I think the Kron has already made it very clear.
Right. Okay. There's another interesting question here, and that was regards to treatment interruptions. So perhaps many of your, many institutions are delivering stereotactic body radiation therapy where there's quite a sensitive timeline in terms of how much dose you're delivering over that time period. So the question is related to what happens in those situations, or have you faced those experiences where there have been prolonged delays during the course of an SBR treatment? And I think the number here was given something like 10 days, but have you had that situation, and how did you address it? So let's start with Thomas.
We did not have that, and SBRT is really sort of really a very broad church. There are clearly cases which can probably be delayed if patients are not symptomatic in an oligometastatic or oligoprogressive environment, while others who come in with pain or symptoms may require treatment directly. We've moved to much more aggressive single fraction treatments wherever that is possible, which basically means that a treatment interruption as such is not a concern. So that's probably the key point, that hypofractionation, even if you think 3 fractions is not hypofractionated, it is already hypofractionated. You can often hypofractionate even further.
And so, Jin, in your situation, did you have patients that were in having their SBR treatments, but then there needed to be changes made during the course of their treatment? And how were you able to adjust? No?
Yeah, actually, we said we opened the radiotherapy just like 4 days before the schedules, as I mentioned in my slides. So we open very quickly but actually for the SBRT, we don't consider these 4 days because we think, like, say, if the treatment lasts 2 to 3 weeks, that's fine. I mean, the total treatment time, like say, postpone for 4 days. So usually we will finish 2 weeks. Now probably we need to finish the SBRT in 3 weeks. I think that's totally fine for the physician side. We do have some patients, like say, postpone for the regular fractions, like say 30 or 25 fractions. Yeah, for this patient, we will like make up 1 or 2 fractions, depends on how long, like 10 days or 5 days they have been postponed for that patients. For the SBRT, so far everything's good.
Okay. Well, we're approaching 8 o'clock, and so I want to respect people's time and our presenters' time and our technical staff's time. So so just some quick final words. If you could just give us one quick sentence on what your words of wisdom would be to impart on to your colleagues around the world. Jin, what would you say was probably a simple one-line word of wisdom that you can say to
keep yourself safe, keep your patients safe, keep your family safe.
Yes, that's a great message.
It's very important.
Yeah. And yourself, Thomas?
I would just remind ourselves that many of us are physicists, and physicists are problem solvers, can improvise, and have generally, at least from my experience, quite a good way of in interacting without trying to be overbearing and be problem focused, and that certainly is something which is helpful.
Yes, excellent points. Thank you very much for all of your wisdom and knowledge that you've imparted. As promised, I wanted to share the location of the guidelines for the AOFMP. If you go to their website, you'll see a button, COVID-19, and if you click on that, you can get directed to those documents that were discussed earlier. And for the guidelines that Thomas had mentioned, they're published on their journal, Physical Engineering Sciences and Medicine. If you click on the most recent article that was published in April 13th, you'll find all of that information there. We'll post links to this information on our MPWB website as well. So quickly, the last slide here is to thank our speakers, Dr. Kron and Jin, for their outstanding presentations. Such great knowledge to hear, especially from different parts of the world. We really appreciate the time and energy you've put into this. I also want to give a personal shout out, or a shout out to Farhana Khan and the AAPM headquarters, who have graciously offered their webinar services to share this knowledge. So thank you so much for doing that. I want to thank the MPWB. I want to thank all the participants, and most importantly, I want to thank all the healthcare workers in the world for helping us get through this challenging time. That concludes the webinar, and so as I mentioned, all of this information will be posted on the MPWB website. It'll be recorded, and we'll send out a link for that as soon as possible through our variety of social media channels and email communications. This concludes our webinar, and I thank you for attending, and keep safe, everyone. Goodbye.
Thank you. Bye-bye.
Thank you very much. Goodbye.
Thank you, guys.